everyone, welcome to MedClinch Academy. As promised, I told you guys that you're going to drop our first mini episode on cardiac biomarkers. So before we begin, those guys who are new, please support our channel. This is a very small channel. Currently, we are at 15 subscribers. I want us to at least hit 1K. So subscribe, follow our social media pages. We are found in Instagram, we are in TikTok, we are in Twitter, and also in YouTube. So share the link to your colleagues. This is a learning forum. So today, as promised from our previous revision, I told you guys that you're going to have some mini episodes just to sharpen our knowledge and skills in matters health. So one of the topics that we identified is cardiac biomarkers. So today we're going to have a brief session on cardiac biomarkers. So I'm certain some of you have heard this term before. So for those who haven't, don't worry. We are going to have an in-depth analysis on what it means. So the first step on this session is to identify the term cardiac biomarkers. What is cardiac biomarkers? So cardiac biomarkers, these are substances. It can be proteins, enzymes, or hormones that are released into the blood when the heart experiences an injury, or when the heart experiences necrosis, or when the heart is stressed or stretched. So when those three happen, the heart will release biomarkers into the bloodstream, and this will help us diagnose or identify what is wrong with the heart. Yeah. So in a broad classification, we can say that these biomarkers can be classified based on what they indicate. For instance, we have got those that are released when there's myocardial injury or necrosis, and under this category, we have got the likes of troponin. We've got two types of troponin, the cardiac troponin I and the cardiac troponin T. So these two are always cardio-specific. We also have got creatine kinase, the CK-MM, the CK-MB, or the CK-PP. But under this category, the one that is commonly used is the CK-MB, the creatine kinase myocardial band. So that is the one that is always specific when it comes to the heart. Same in this point, I want to differentiate two terms. This term creatine and this term creatinine. So these are two separate definitions or two separate terms. So you have to know how to differentiate these two. So here we have got creatine, not creatinine. Creatinine is a waste product that is always released by the kidney. So here I've got creatine, an enzyme, that is always found in the muscles. So another thing that you have to know is the myoglobin also may be released when there's a myocardial injury. We've got the lactate dehydrogenase and also the aspartate aminotransferase, or also called the AST. So these five are always released when there is a myocardial injury or necrosis. Forward, also we can also classify the biomarkers based on the myocardial stress and stretch. Yeah. In here we've got in myocardial stress or stretch. These are the biomarkers that are released when the myocardium is stressed or stretched. Yeah. It may be due to volume overload or pressure overload. And here I've got the BNP, also called the B natriuretic peptide. I've got the NT-proBNP, yeah, the N-terminal pro-BNP, and also you may also have the ANP. The other ones that are not so common, just to mention, there are those which can also be released when there's an inflammation, like the high sensitivity C-reactive protein. I've got the copeptin and also the heart type fatty acid binding protein, or the HFABP. Also those ones that are released when there's thrombosis or hemostasis has occurred. It may be related to the heart. We can have the D-dimer, which always tell us that a clot has occurred somewhere. But also the fibrinogen. So those are others that you have to know. But for this session, I'm going to basically focus on those that are released when there's myocardial necrosis, and those that are released when there's a myocardial stress or stretch. Now, let's just begin with the first one. Those ones that are always released, or we call them the markers of myocardial necrosis or injury. Yeah. So these ones are the most common one. These are the ones that you come across maybe in an exam or in practice. Yeah. The markers of myocardial necrosis and injury. So we're going to begin with the first one, the first common or the first popular one that you have to know. The first one that is commonly set in exam, or the one that you have to know, is the one that is called troponin. Yeah, we have got two types of troponin. You've got the cardiac troponin I and the cardiac troponin T. So these are always the gold standard when it comes to cardiac biomarkers. Yeah. So what's the term troponin? Certain you guys, when you did physiology, especially the physiology of muscle contraction, you came across this term called troponin. So how do we define troponin? So troponin, these are regulatory proteins of the actin myosin complex. Yeah, they always regulate the cardiac muscle contraction. Remember, in our definition of cardiac biomarkers, I told you guys that these are substances that are released when there is an issue with the heart muscle. If you see in this diagram here, what happens when you have got a blockage in the coronary artery, the supply of blood will be interfered with. Yeah, there will be insufficient oxygen supply to the heart muscle, and when this occurs, ischemia will occur. And when this is ischemia, we know that this will lead to necrosis or muscle damage. So when that happens, this troponin that will be released, and they'll help us diagnose an issue or something that is wrong with the heart. So troponin is always very good when it comes to it's actually a gold standard when it comes to diagnosing heart muscle injury. Apart from that, also you have to identify the cardiac specific isoforms. We know that I've got the two common ones, the cardiac troponin I and the cardiac troponin T. So these ones, they're cardiac specific. They differ from those that are released from the skeletal muscles. But remember also, you may come across something called troponin C. So this one is rarely used here because it's identical when it comes to both cardiac and skeletal muscle. Yeah. So because there is no cardiac specific isoform, TNC is never used as a cardiac biomarker. So when you go to the lab test or you see the biomarker test being carried out, you only see the CTNI and the CTNT. Yeah, that's the troponin I and the troponin T. Those two are the ones that are commonly used. Troponin C rarely, because it's very identical with the one that is also released by the skeletal muscles. Yeah, so these two they tend to rise 3 to 4 hours after injury, and they're very sensitive to the cardiac muscles. That's why they're always used as a gold standard. That being mentioned, also you have to know when they peak and when they return to the baseline. Yeah, it will help us know when to diagnose this injury. So when it comes to peak, they always peak within 12 to 24 hours. Yeah, they hit the peak within 12 to 24 hours. And they may return to the baseline depending on which isomer. For instance, if you see the cardiac troponin T tends to remain elevated for a longer period of time compared to the troponin I. Yeah, so here you can see in the screen, they tend to return to the baseline from day 7 to day 10, but they differ. For instance, you can see the cardiac troponin I tends to return from 5 to 10 days, while the cardiac troponin T tends to remain longer, between 10 to 14 days. In terms of sensitivity and specificity, they are very high for myocardial injury. So when there's myocardial injury, these two tends to be extremely elevated, and that's why they're gold standard. Yeah, high sensitivity troponin assays now standard in most labs. So these two, they're the most standard. They're the ones that are commonly used or commonly ascribed to when it comes to diagnosing myocardial necrosis or myocardial injury. So they're best because, number one, they're highly sensitive, they're highly specific, and they detect very small myocardial injury. So they remain elevated for several days, gold standard for diagnosing myocardial infarction. So they're very good when it comes to diagnosing myocardial infarction. Yeah, yeah. So that being mentioned, also, let's go to other causes. So the elevation of troponin, it not only occurs when there's an MI, it may also occur when there's other pathologies. For instance, it may also be elevated when there's renal failure, when there's sepsis or critical illness, when there's pulmonary embolism. It can also occur when there's heart failure. It may also be seen in myocarditis and pericarditis. It can be seen in tachyarrhythmias. It can also be seen in strenuous exercise. It can also be seen in Takotsubo cardiomyopathy. It can also be seen in cardiac contusion, cardioversion, ablation. So those are some of the conditions that can also be seen when there's an elevation of troponin. Now, that being said, I want us to go to the next commonly used cardiac biomarker, and that is the creatine kinase-MB, or the creatine kinase myocardial band. So that's another biomarker that is very popular and commonly used. So what is CK? CK is an enzyme that is found in muscle. There are three isoenzymes. The CKMM. This one is also this one is always elevated when there's a skeletal muscle damage. We've got the CKMB, which relates to the cardiac muscle. We've got the CKBB, which tends to be related to the brain. So in terms of structure, the myocardial band isoform of creatine kinase is enriched in cardiac muscle, but not fully specific. So that means it can also, despite it being specific to the cardiac muscle, you may see its elevation also when it comes to other muscle injuries. Yeah. So it's good, yes, but it's not fully specific to the cardiac muscle. So it may rise within 3 to 6 hours. It peaks between 12 to 24 hours, and it returns to baseline within 24 to 72 hours. Unlike troponin, this one tends to clear fast. So these are the CKMB is very good when it comes to diagnosing myocardial the MI reinfarction. Yeah, because it tends to return to the baseline quick within 72 hours. So when there's a reinfarction, it may again be elevated. So that being said, it's very good when it comes to diagnosing a reinfarction. Now, so one of the clinical use I've told you guys that is very useful for detecting a reinfarction. Why? Because since it normalizes faster than troponin, a new rise indicates a re-injury. So if CKMB rises again after initially falling, it may indicate a new infarction. So if you want to identify a reinfarction, the best test to go for is the CKMB. So nowadays, you know that it's largely replaced by troponin for primary diagnosis. So for primary diagnosis, we tend to go for the troponin, yeah, both the troponin I and the troponin T. So one of the limitations here is that this CKMB it's also present in skeletal muscle. So it may give a false positive in trauma or in rhabdomyolysis or in muscular disease or in surgery. So you have to note that. Now, when it comes to, let's go to the third one. The third biomarker that is commonly used is the myoglobin. What's myoglobin? Myoglobin is a small oxygen-binding heme protein that is found in cardiac and skeletal muscle. We know that it tends to rise. This is the earliest riser. It is the earliest. It is the first. Is the one that tends to rise early. Yeah, within 1 to 2 hours, you can see it in blood. So it peaks within 4 to 12 hours. So this is the earliest marker, but least specific. Why? Because it can also rise when there's injury to other muscles. Yeah, so it's helpful for ruling out MI if serial measurements remain negative. And in terms of clinical use, so it's historically it was used for early rollout due to fast kinetics, largely obsolete now given high specific troponin or high sensitive troponin. So nowadays, because of troponin, we don't use myoglobin that much. Yeah, but it can be used. It can be used when you want to rule out when you want to rule out MI. So limitations, I told you guys that this one is not cardiac specific. It also may become elevated in any muscle injury or in renal failure. So the poor specificity of this myoglobin is the reason why you don't use it. Yeah, it's the reason why we go for troponin. So poor specificity because of skeletal muscle injury also elevates myoglobin. So when you've got other injuries, we may also see an elevation of myoglobin. So it's not specific to the cardiac muscle. Yeah, so that's something that you have to note when it comes to myoglobin. Those three are the common ones: the troponin, the creatine kinase-MB, and also the myoglobin. Those three are very common. But that being, we also have got other ones that were used previously or may be used in modern days. And there are two which I want to mention before we move to the next one. So we have got the lactate dehydrogenase, the LDH. So this one, LDH, nowadays is not used, but it's an older marker. So LDH is an intracellular enzyme in many tissues. Number one, it's an enzyme that is found in many tissues. It has got 5 isoenzymes. You've got the LDH1, LDH2, LDH3, LDH4, and LDH5. The LDH1 is the one that tends to be found in the heart. The LDH5 may be found in the liver and skeletal muscle. So these one are the older markers that are specific. They've got a rise late and rarely used now clinically for MI diagnosis. So they were used historically, but nowadays we don't use the LDH. We also have got the ST or the aspartate aminotransferase. I know this one you have heard this before, especially when it comes to LFTs. So this one here, they were previously used for diagnosing MI, but nowadays we don't use it because it's not cardiac specific. It can also be elevated when you have got liver disease, especially the hepatocellular injury. It can be seen in skeletal muscle injury. It can be seen in hemolysis. And that being said, this one is not used in diagnosing cardiac muscle injury. If you do LFTs, it's one of the common enzyme that is always seen when it comes to hepatocellular injury. Yeah, so these two also can be used, but they were used historically. So the three major used ones are the troponin, the CK-MB, and the myoglobin. But you also have to know of the lactate dehydrogenase and the aspartate aminotransferase. Now let's move to the other markers. So apart from the markers of myocardial necrosis or injury, we also have got markers of myocardial stress or stretch. And these are very useful when it comes to identifying or diagnosing a heart failure. So the one that is used here is the BNP or the NT-proBNP. The BNP basically it means it's the B-type natriuretic peptide. The NT-proBNP is an advanced form of BNP. So these one are released by ventricular myocytes in response to wall stress or stretch. This may happen in volume or pressure overload. We know when there is a heart failure, one thing that you have to remember is that I told you guys when we looked at hypertension, other factors that tend to impact hypertension is the preload. Yeah. So when there's a preload, what happens? There will be when there's an increase in the preload, it means that the ventricle will stretch beyond limit. Yeah, and this when this happens, these markers will be released in response of an overstretch. Yeah, this may happen in volume overload or in pressure overload. In pressure overload, this may occur when there's an increase in the afterload. We know that afterload is the pressure that the left ventricle has to overcome in order to pump blood to the body. So when there's an increased afterload, an increased afterload leads to a pressure overload, whereas an increased preload leads to a volume overload. So that's something that you have to note. And these two tend to happen when there's a heart failure. So when the markers of myocardial stress or stretch will be seen when there's a release of BNP and the NT-proBNP. So pro-BNP is cleaved into active BNP and inactive NT-proBNP, biologically inert but longer half-life, more stable in vitro. So in terms of half-life, BNP is 20 minutes. The NT-proBNP is within 60 to 120 minutes. That being said, the NT-proBNP levels are typically higher and more stable for storage and lab measurements. So we tend to use the NT-proBNP, because it has got typically higher levels and more stable for storage. So another additional information on this subject in terms of clinical use, they're used in diagnosing and excluding heart failure in patients with dyspnea or high negative predictive value, prognostic marker in heart failure and acute coronary syndromes. So it's also good when it comes to monitoring response to heart failure therapy, trend more useful than single value. So they can also be elevated in renal failure, in AFib, in pulmonary embolism, in sepsis, in advanced age, or even in female sex. They can be low in obesity because adipose tissue tends to, it clears natriuretic peptides. Flash pulmonary edema may not have seen yet, and also heart failure with reduced ejection fraction. So apart from BNP and NT-proBNP, we also have got the NP, all the atrial natriuretic peptide. So this one here, it's always released from atrial myocytes in response to atrial stretch. So this one here, this one does not indicate a pathology. This one tends to be released when the heart is trying to respond towards an increased blood pressure. So it's released from atrial myocytes in response to atrial stretch. And atrial stretch tends to happen when there's an elevation of a preload or when there's an elevation of the venous return. So that's when you've got NP being released. And what happens? The NP, basically it tries to negate an increase in blood pressure. It will, number one, it will lead to natriuresis. It will excrete sodium ions. It will lead to excretion of water. It may lead to vasodilation. and it may also decrease the renin production or the aldosterone production. All this aim is to relieve the arterial stretch, to reduce the volume overload, yeah, to reduce the blood pressure. So that's why this marker tends to be released. It actually helps the body to reduce the pressure. So instead this one, it is a biomarker of cardiac volume overload and plays a vital role in regulating blood pressure and fluid balance. So it's always released with an aim of regulating blood pressure and fluid balance. So apart from that being mentioned, we've got other markers that I don't want to explain. This one may be seen in other topics, but we've got markers of inflammation and plaque instability, the likes of high sensitive C-reactive protein. You've got the myeloperoxidase, the MPO. You've got the lipoprotein associated phospholipase A2. So these three are always markers of inflammation. They are not commonly, they don't come in exam that much, but you can just see them maybe when reading some notes. Yeah. We also got markers of thrombosis or hemostasis. This one is very common. You know, the dimer. Dimer is a very useful test. It's always very common for those, if you suspect a pulmonary embolism, you tend to do the dimer. The dimer, what it does, it shows that a clot formation has occurred somewhere. Yeah. So the dimer is a fibrin degradation product. So it's always elevated with clot formation and breakdown. So when you break down the clot, we always release the dimer. And this sample in blood tends to help us diagnose, or it tells us that a clot occurred somewhere. And it may be useful when it comes to a cardiac biomarker, because when there's a clot in the coronary artery, it may lead to an MI. It may block blood supply to the cardiac muscle. So we also need to check the D-dimer. It's very useful. So number one thing that you have to know when it comes to D-dimer, it's not cardiac specific, but relevant in ruling out pulmonary embolism and aortic dissection. So very high sensitivity and poor specificity in the differential of chest pain. So that will be carried out. We also have got the fibrinogen acute phase reactant associated with increased cardiovascular risk when chronically elevated, but not diagnostic acutely. So those are some of the markers that you have to know. But the three markers that you guys have to know: number one, the markers of myocardial necrosis, the likes of troponin, CK-MB, myoglobin. You can also look at the LDH, yeah, and AST. Then you've got the markers of myocardial stress and stretch, the likes of the BNP or the NT-proBNP, and also the NP. But the NP, it's always released when the heart is trying to correct the volume overload. So that's something that you have to know when it comes to this topic. Another thing that you have to know is that the gold standard is the troponin. Yeah, the earliest biomarker to rise is the myoglobin. Yeah, and the one that can be used for re-infarction is the Creatine Kinase-MB. So those are the 3 points that you have to know when it comes to this topic. So thank you for your time. I hope you guys will have an amazing session. And at the end of this, you've got 3 questions that you can attempt. It will help you learn more.